Alright, now it's time to talk about HHS. What's it called? Hyperglycemic hyperosmolar syndrome. Basically, we can break down the name to figure out what the hell is going on. Look at that little... I'll show you that later. It's Christmas background. Hyperglycemic, we're talking hyper. Blood sugar is over 600. Also, you're always going to see this in type 2 diabetics only, whereas with DKA you usually see it in type 1, but you could see it in type 2. And as we know with type 2, I'm sorry, my brain's just resetting because no one seems to care that I'm trying to study. Because we see this with type 2 diabetics, it's important to remember that there is still insulin in the body. It's just not working as well as it should be. So we're not going to see the ketone bodies in the urine because the body's not going to go into that, oh shit, there's no way to get sugar in these cells. It's going to do some other funky shit. So let's talk about another component of this. So we talked about the hyperglycemic detail. Let's talk about what hyperosmolar means. Let's talk about what osmolarity is first of all, before we get into this. So osmolarity just refers to the concentration of dissolved particles in the blood. So if something is a high osmolarity, there's a lot of dissolved particles in it and not as much water by comparison. If there's a low osmolarity, there's going to be a lot of water compared to the number of dissolved particles in the blood. So what we're having with the hyperosmolar component of this is we're seeing a lot of water being excreted. One of the clinical manifestations of HHS, which maybe we should get into that first, but one of them is polyuria, lots of peeing, dehydration. So if the cells are excreting a lot of water, it's going to lead to dehydration and it's going to lead to a high osmolarity. Essentially, there is not going to be as much water in the blood, there's going to be more dissolved particles in the blood. So that's why we're going to see high serum osmolarity when we look at the labs here. Let's talk about some of the other clinical manifestations. We already mentioned that we're going to see blood sugars 600 or higher. I mean, we're talking really high blood sugars. You can remember DKA is usually between 250 and 800. And again, there's some other differences between the two conditions, but just remember HHS, they're not kidding when they say hyperglycemic, like it's up there. We're going to see the polyuria, we're going to see dehydration. You can think of those two together. I mean, one's going to lead to the other. The body's trying to excrete all that extra sugar. We're going to also see tachycardia, hypotension, and we'll eventually see some neuro changes. You'll remember with DKA there were also some neuro changes. So just remember both of them can fuck with your brain, because guess what? Your brain needs sugar as well. I mentioned this already, but with HHS, we're not going to see urine ketones because, again, there is still insulin present. It's just not working as well as it should be. But your body's not going to go into that acidosis because there is still some insulin and it's still working a little bit. So the body's not going to go into having the liver break down fats and all that shit because it's still trying to get that sugar in the cells. So because there's no ketones, there's also going to be a normal pH, normal bicarb, so we're not going to be in metabolic acidosis for this. But because of that hyperosmolarity, all the water leaving the cells, trying to flush out that sugar, we are going to see that high serum osmolarity. And you can imagine with the kidneys going into overdrive here, trying to flush all that out, we're going to see high BUN and high creatinine. You'll remember with DKA, there was a little something about potassium levels being different, being low. Well, here, potassium won't be low because there is insulin, some of it is working, and it is letting sugar go into the cells, and when the sugar's going into the cells, the potassium can leave the cell as needed. So that's why we're not going to see that here. We're really going to see issues related to that high sugar and that dehydration from all the diuresis and polyuria. So, and if you think about it, if you're, really dehydrated, you do tend to have a lower blood pressure. So that's how you remember hypotension. Tachycardia, I guess you just think about the body's working real hard. I don't know. Just think of it that way. It's like, oh shit, we gotta get rid of this sugar. I'm gonna remember it as every time I have like a high sugary meal, usually my pulse gets higher. So don't think about it too much. Just go. You might be thinking, all right, let's get that sugar lowered, but not so fast. What we want to do is fix everything. Relatable, right? So we're just as concerned about the dehydration and the high serum osmolarity as we are with the hyperglycemia. So our priorities of our treatment is actually, like I said, kind of do everything at once. We want to rehydrate using IV fluids. We want to restore the electrolyte balance to what it should be, and particularly sodium. And we also want to do IV insulin, of course, regular insulin. We're going to use an IV pump for that, just like we would with DKA. So that is part of the issue, but the other part of the issue is that the body is trying to diurese all of this extra sugar. So that's also a major player here. So IV fluids are just as important as the IV insulin. It's also important to remember that with DKA, that insulin administration is very important, not just because of the hyperglycemia, but because of the ketoacidosis. But with HHS, we're not in metabolic acidosis, so there's no need to correct that, so that's not as much of an urgent finding. It's part of the problem, the high blood sugar, but it's not leading to that level of problems. A big problem here is dehydration and the fluid imbalance and what that's doing to the body. So that's why with HHS in particular, we really want to focus on rehydrating and restoring the electrolytes, but also lowering the blood sugar, but that's why it's not first on the list. And of course, just like with DKA, you're going to be monitoring a lot of the same things: the blood sugar, the INOs, the labs, and just generally keeping your patient safe. And it's going to be a no on the turkey sandwich. So, good luck explaining that.